Hello?
Down.
Can you hear me? Great. Welcome. We are getting set up to start the presentation on sleep disorders. I know this is an impact that a lot of people suffer with, whether you have Parkinson's or not. Today, we have a very good speaker. I just have recently met her, but I can already share with you she's a fun person, so it'll be a good presentation. And I'd like to go ahead and just introduce her. Her name is Juliana Atem. And she is a nurse practitioner at the University Veterans Administration Medical Center for a little over 2 years now. Prior to joining the VA and fulfilling her desire to serve veterans, Juliana was an NP at the Movement Disorders Clinic at UT Southwest Medical Center for over 5 years. She obtained her master's in nursing in 2014 and obtained a certification in acute care adult gerontology. She's been in nursing since 2007, when she has worked in several different areas. She enjoys interacting with her patients, providing patient education, and demystifying some of the myths about Parkinson's disease. She spends her time catering to her family's needs and enjoys listening to music and dancing as well. With that, I'd like to introduce our guest speaker today, Juliana. Juliana, come on down.
Good morning, everybody. It's good to be here. I'm extremely excited, so pardon me if I raise my voice a little bit because excitement does that to me. Thank you for the amazing introduction. I am Juliana Atem. I'm a nurse practitioner with the VA. I've been at the VA a little over 2 years. I was at UT Southwestern for several years. So for those of you who have been at UT, you know I learned from the best. However, I don't claim to be amongst the best. So without further ado, let's talk a little bit about sleep. This is going to be more of an interactive presentation, so if I say a few things and you have some clarification questions, I can stop and we just move forward, okay? And I'll try to see if I can work this thing perfect. The objectives of my presentation today is, number one, just understanding the importance of sleep in people with Parkinson's. Number two, talk about some of the causes of sleep issues in Parkinson's. And then talk about the common sleep disorders in Parkinson's. Of course, we're not going to address every single one of them, but we will address the most common of them. And then we'll talk about treatment options, we'll talk about medications, and then most importantly, we'll talk about how to take charge of your sleep. Just like we talk about how to take charge of your life with Parkinson's, we're going to talk about how to take charge of your sleep when you have Parkinson's disease. That is a little too busy, but I needed some of that information up there for myself. The importance of sleep. Not just in Parkinson's, but as a whole. We know that research has told us that about 930,000 people live with Parkinson's disease, and up to 98% of those with Parkinson's have some kind of sleep disorder. So that tells me sleep is really an important aspect to talk about when you're managing Parkinson's disease. The importance of sleep, therefore, cannot be overemphasized. Sleep enables the brain to rest, to rejuvenate, and it enables the neurotransmitter to regenerate as well. Sleep also is a key factor in diagnosing Parkinson's because a lot of our Parkinson's patients will tell you, several years before I got diagnosed, I had this kind of issues with sleep. Especially the REM behavior, the talking and fighting and all of that stuff in your sleep. Sleep disorders could, like I said, be an early sign, and patients who do have sleep disorders generally develop Parkinson's disease. Not every single one of them, but we find out that our Parkinson's patients, a good portion of them had some kind of sleep issue several years prior to diagnosis. Sleep disorder can also be a result of damage to the central nervous system, and some research attribute poor sleep as a cause of acceleration in the disease process. Not everyone experiences that again, but there are some patients who, because of lack of sleep, their disease tends to progress a little bit further. Sleep-related symptoms may be one of the earliest features. I'm repeating myself again. It may be one of the earliest features of Parkinson's disease, so that's super important. REM sleep behavior disorder may be the earliest indication of Parkinson's disease. REM sleep behavior disorder convert to Parkinson's disease and other synuclein-related disorder like dementia, dementia with Lewy body, multiple systems atrophy. Looking at the phenoconversion, meaning people who had REM sleep behavior, 15 to 35% of them develop Parkinson's in 2 to 5 years, as well as 41 to 90% of them develop Parkinson's some 12 to 25 years later. So it's one of the most important specific clinical prodromal markers. So one of the most specific symptoms that if a patient has Parkinson's, majority of the time, 90% of the time, they'll tell you, so many years ago, I used to talk and fight in my sleep. While, like I said, not everyone that does that has Parkinson's, but a lot of patients who do that are diagnosed with Parkinson's sometime down the line. Some causes of sleep disturbance in Parkinson's disease. As we know, Parkinson's is a disease that traditionally affects us as we age. Aging by itself, as we age, our sleep patterns change. Because of the change in our sleep patterns, we can have sleep issues, just the general population. Then plus when you have Parkinson's, it makes it a little bit more prevalent. There's a change in our circadian rhythm, the change in the way our body recognizes sleep, the change in the way our body processes this whole, I need to go to bed, I need to rest, I need to sleep. And with that, our blood pressure changes, our body temperature, our heart rate, everything changes as we age. Sleep is not an exception. As people age, the body's circadian rhythm shifts forward in time. So you get to be in a space where it calls the phase advancement. You don't want to go to sleep on time. When you're younger, your body shuts down earlier. The older you get, your body does not want to shut down. So it's important, again, like I said, to take control, to be able to put things in place to address and manage your sleep. Depression and anxiety, pretty common in our Parkinson's population, also causes issues with nighttime sleep. Frequent urination, getting up. You need to get up multiple times at night to use the bathroom. That interrupts your sleep. Multiple other medications, polypharmacy. You're taking too many things. Some of those things cause sleeplessness. Some of those things make you sleepy. That interrupts your sleep pattern too. And of course, our stimulants, the coffee, the alcohol, the tobacco, things like that affect your ability to maintain a good night's sleep. This picture right here just depicts that when we're younger, you tend to get more time in your deep sleep. It takes you a shorter time to fall asleep, and you stay a little bit longer in the REM sleep behavior. And that's just traditional in the REM sleep phase. And that's just the natural nature of things. As we get older, this is not in Parkinson's patients necessarily, it's in the general population. The older we get, we don't sleep as long, we don't sleep as deep. It takes us a little bit longer to go to sleep. What are some of the common sleep disorders in Parkinson's disease. Sleep deprivation, nighttime motor disturbances, doing things, disruptions in your sleep, disruptions during your sleep, sleeping a lot during the daytime, having difficulties going to sleep or difficulties maintaining a good night's sleep. REM behavior disorder, again, the talking, the fighting, the screaming in your sleep. Restless leg syndrome. For some people, obstructive sleep apnea, which is breathing disorders during sleep. I'll just let that slide sit right there, and I'll take a breather and ask if anyone has any questions so far, or if everybody's following me.
Yes, I was wondering, I have fibromyalgia, and I was diagnosed with it in 1983. I wonder if that would have any bearing on my developing Parkinson's later on in life, because fibromyalgia interrupts your sleep so much, and I've had that problem all these years.
Yep, 85, that's a long time. Not that I'm aware of. We don't have any studies linking fibromyalgia to Parkinson's disease, but I can see a correlation where not having good enough sleep can interrupt your disease process. But being a causative factor, being a direct link, we don't have, I'm not aware of any studies that do link both of them.
Well, I also developed sleep apnea about 5 years ago, so I'm wondering whether all those were like a progression leading up to Parkinson's.
I would not say leading up to Parkinson's, but I would say that having Parkinson's, all those things will make your Parkinson's seem a little bit worse. It'll make it a little bit more difficult for you to manage, because once you're in chronic pain, which is what fibromyalgia means, and you have interruption with breathing during your sleep, you might feel like you have had a good night's sleep, but you wake up feeling very restless. And once you're not well rested, nothing else falls in place. So sleep is extremely important. If you don't have a good night's sleep, it interrupts everything that you do during the day. So I would see where all of those additional things would make your Parkinson's some days to be more challenging than others, especially if you didn't have a good night's sleep and you were in pain throughout the day. Those days will be more challenging than a regular day where you have a good night's sleep. But I wouldn't say that there's a direct link to having this causing that. Does that make sense? Yes. Sure.
Okay. How can you be a light sleeper and you having these behaviors, with your sleep, talking, cursing and fighting in your sleep and not wake yourself up?
We'll talk about that. I'll get to the REM sleep behavior, and we'll talk a little bit more about that. Yes, I'll answer that question for you. Can we move forward? So I went ahead and broke down some of the common sleep disorders in Parkinson's, and I did give some little background information on them. Sleep deprivation just simply means you're not having adequate quantity or quality of sleep. So you might be in bed for 10 hours, but you only slept for 5 hours. So that's sleep, you could be sleep deprived. Sleep deprivation also, you want to sleep, but you can have problem maintaining sleep, or you can have problem just going to sleep. Disruptions during your sleep, the vivid dreams, the nightmares, the REM behavior disorders that are unique to Parkinson's. REM behavior is a rapid eye movement. That's what REM stands for, the rapid eye movement. That is when you're supposed to be at your deepest sleep. And if somebody is watching you critically, your eyes act like they're moving. And in our Parkinson's patients, we do see that a lot of them during this state of sleep, they're actively engaging in some kind of activity. The average person during REM sleep might have a dream, but the way our system is naturally set up, you're paralyzed to where you can't get up and fight. You can't respond. So somebody's talking to you in your sleep, or you're fighting, you're in a dream state, you can't respond. But in Parkinson's patients, they're able to respond. So therefore, they're deeper sleep, and they're fighting with someone, and they're actually swearing at that person, cursing, throwing their hands, and hitting their spouse unintentionally. So that's the REM sleep behavior, which is very unique to Parkinson's, that we're going to talk about in-depthly. Hallucinations and delusions at night will keep Parkinson's patients awake. Confusion at night due to sundowning, a little bit of early dementia in some patients, that would keep you awake as well. Excessive daytime sleepiness. You sleep a lot during the daytime, you don't have enough sleep left in you to sleep at night. That will keep you awake as well. Obstruction in your respiratory system. Sleep apnea. You have sleep apnea, you don't sleep well at night, you don't sleep deep enough at night, you don't feel rested, you have to nap in the afternoon, or you have to sleep sometimes in the afternoon, and that interrupts your sleep as well. This little table diagram right here, I was just creating a picture of how all of this intertwines. Parkinson's disease plus sleepiness, daytime sleepiness, excessive daytime sleepiness plus Parkinson's disease. There was a research study that did show that patients with Parkinson's, about 18% of them have excessive daytime sleepiness, fall asleep a lot during the daytime. About 35% of them have sleepiness just in general. You just feel fatigued, you just feel sleepy all the time. We have the REM behavior disorder in about 35% of patients as well. And patients with excessive daytime sleepiness and REM behavior disorder was about 19% of the Parkinson's population. That was researched in this study. Insomnia, it's another common sleep disorder in Parkinson's. And insomnia just means you have trouble falling asleep, or you have trouble staying asleep. So there's the early phase insomnia, and there's the late phase insomnia. You have difficulties falling asleep. Some people say, I fall asleep just fine, but I can't stay asleep. Can be short-term, can be long-term, and it can be chronic. It's common in the general population, but it's more prominent in our Parkinson's disease patients. Primary insomnia is if you have insomnia prior to being diagnosed with Parkinson's, that's primary insomnia. If you have insomnia as a result of Parkinson's, sometimes that just means we need to adjust your Parkinson's medications. So it's very important to, when you're talking to your provider, your clinician, to let them know, I've always had sleep issues in my earlier years, because the way we address that, the way we treat that is different from, I can't go to sleep because of my Parkinson's, because I'm shaking, because of this, because of that. Because that we treat a little bit differently, because that means we need to treat your Parkinson's and not the sleep. The rapid eye movement behavior disorder, one of the most common. These patients, Parkinson's patients in general, because rapid eye movement behavior happens also in other diseases. It happens a lot in post-traumatic stress disorder. But most importantly, it happens in Parkinson's patients, at least 35 to 50% of them. What happens during that time is there's a lack of inhibition, which normally happens in regular, normal people as we go to sleep. At that time, when you're having that deep sleep, where your mind is supposed to be relaxed, your body is supposed to be paralyzed, it does not happen in Parkinson's patients. Not every single one of them, but some of them. And when that doesn't happen, then somebody comes at you in your sleep, you're able to act. You're able to respond while you're still completely asleep, but you're responding. And the person next to you can wake up, but you can't wake up because your brain is actively sleeping. Then we have restless leg syndrome. The restless leg syndrome phenomenon, it's not you moving your leg in your sleep. It's your brain telling you that leg cannot stop. It's moving. It might not be physically moving. It might be internally moving. It might be cramping. Whatever it is, if you have to wake up and go walk around and go do something because of that internal feeling that your leg is not shutting down, then that's restless leg. And that happens a lot in Parkinson's patients. What we use to treat restless leg syndrome is dopamine, which is what we use to treat Parkinson's. So therefore, there's a correlation there with restless legs and Parkinson's disease. Restless legs, sometimes we can just diagnose it in clinic based on what you tell us if it meets clinical diagnostic criteria. Sometimes we can have you have a sleep study, and the sleep study helps us diagnose the restless leg as well as the periodic limb movement disorder during sleep. The REM behavior disorder, that's classic. That's a classic picture of what's happening. So you're deeper sleep, but you're fighting in your dream state. That is way up there. You're fighting in your dream state, so you're actually acting in your sleep, but you're clearly deep asleep. But your body is not inhibited like it's supposed to, so you're not staying asleep. You're actually acting. And it might be confusing to comprehend, but if you ask your spouse or your bed partner, they'll tell you that you're deeper asleep, but they can see you flinging and talking and swearing, whatever it is that you're doing, whatever is coming at you, you're trying to defend yourself. Sleep apnea is also a common disorder that we see in Parkinson's patients. Sleep apnea could be central sleep apnea, which is usually when the brain fails to send a signal to the muscles to shut down and fall asleep, or it could be obstructive sleep apnea when sometimes you snore a lot. There's a difference in your respiratory system doesn't collapse like it's supposed to, then you have difficulties maintaining a good night's sleep. A lot of times patients get treated with a CPAP or a BiPAP to help that airway, keep it open, help your breathing during your sleep so you can get a good night's sleep. Usually in patients with sleep apnea, we need to get a formal diagnosis. We need to get them to see a sleep specialist and get tested and be on the right breathing equipment. And we encourage them to use those equipments, because one of the things patients tell me is, it's too cumbersome. It makes me feel clustered. I can't sleep with that. And recently, there are a lot of newer things that have come up that have been manufactured, newer equipments that make it easy, that is not as cumbersome. I encourage every patient of mine who has sleep apnea to use their device because it improves your sleep, it gives you that restorative sleep, it also improves how you function during the daytime. Before we delve into the treatment, there you go.
Hi. So in dreams, is there a reason for a bad versus a good one?
Not any specific reason for that. I personally will tell you, in some studies that I've read, sometimes it depends on what was going on with that person during the daytime. So people that have a lot of bad nightmares, I tell them, don't watch horror movies before you go to bed, because you relieve them in your sleep. And while you're relieving them, you're acting them out. I mentioned earlier that it does happen a lot in patients with PTSD. So patients who've had some kind of trauma, when they're sleeping and they have those dreams, it's usually the traumatic experience, hence the fighting and the swearing and the cursing. So we don't know exactly why you would have a bad versus a good dream. And a sleep expert might know, but I personally don't know. But the few things that I've read have told me that a lot of times it translates into experiences during the daytime while you're wide awake, and also sometimes into experiences that you have had in your lifetime.
We found recently that before we close our eyes, we listen to a tape, of trees.
Meditation.
Meditation stuff. And it seems to work pretty good. Seems to really put you to sleep. Music, yeah.
Yep,
So why doesn't everybody use it?
yep. So that's one of the things. So you've taken charge, right? So that's one of the things that we talk about, taking charge of your sleep. So doing those little things, making those little changes that can help improve your sleep. Any questions? Treatment options or medication options in Parkinson's disease sleep disorders. First of all, we have to determine which sleep disorder are we treating. If a patient has insomnia, is this primary? Was it insomnia that they've had all their life, like myself? Or is it Parkinson's-related insomnia? Do we have to treat their Parkinson's symptoms, or do we have to treat the sleep? That's the first thing that we have to determine. And as most of you know, our clinic time is really short. So it's important to know these things to give the right presentation, because I only use what you tell me. 90% of the time, I use what you tell me to make a decision on what to do for you. And if you don't tell me the right things, the outcome might not be what you want. Address the main issue. We change medications. Sometimes we have to assess your Parkinson's disease medication and your non-Parkinson's disease medication, because some of your medications that are not treating your Parkinson's can be causing you to stay up late at night and not be able to have a good night's sleep. I work for the VA, like I said, and to the benefit of that is I have access to what the patients are taking. So it's easier for me to look on my list and say, oh, let's take this out. Let's change this from nighttime to morning time. I'm going to tell your primary care doctor we'll do this and do that. In patients who are not in a setting that's as coordinated as the VA is, it's harder because you go to the appointment, you don't have your medication list. You don't know all of those things off of the top of your head. And then you tell your doctor and they add something on that might just not work with something that you're taking at home from a different doctor. So take-home message is have a list of your medications in your have it on your phone, have it with you in your medication cabinet or in your file that you take to your doctor's appointments. So if you have a question, you could say, these are all the things that I take. Do you think any of them, right off of the top of your head, would cause me to have this kind of issue? And again, lifestyle changes. Lifestyle changes is one of the main things I recommend. When do you go to sleep? What are the activities you do before going to sleep? If you pee a lot during the nighttime, are you drinking an hour before you go to bed? Do we need to cut down on what you drink and when you drink before bedtime? If you have sleep apnea, have you been evaluated by a sleep specialist? Have you been evaluated? If yes, do you use the equipment that are recommended? Because if you don't, then you're not doing yourself a favor. You're doing yourself a disfavor by not using the recommended equipment. Again, if you're already diagnosed, I encourage compliance. There are some natural substances that have been mentioned to be helpful in patients with sleep. No, I personally don't know too much about those. I mention those because they have been mentioned and patients talk about them all the time. But I don't have any research backing those up, so I traditionally don't recommend those things. Not to say it doesn't work, I just don't recommend it because I don't have enough research information on them. Like the valerian root, chamomile tea, lavender, stuff like that. I don't push those because I don't know much about them. One thing that is natural that I push a lot is melatonin. Melatonin is a natural ingredient. It's not FDA. The FDA does not have control over it, so it's over the counter. But it is an ingredient that has been researched in several Parkinson's disease articles and Parkinson's disease studies, and it does show that melatonin helps, especially in patients with REM behavior. That fighting and talking in your sleep, melatonin helps a lot. It just helps restructure your sleep cycle for those that have difficulties going to sleep or staying asleep. It helps them a lot. It can cause you to wake up in the morning feeling groggy and sleepy if you take it too late. So you want to take it, give yourself, okay, I want to wake up tomorrow at 6 o'clock in the morning. Try to take your melatonin at 6 o'clock the night before. That means you might go to sleep at 7 or 8, but when you wake up alert. Yes.
Somebody to take.
So that is usually patient specific. I'm very traditional and conservative in how I manage things. So I generally start, if you're 75 and over, I generally start you with 1 milligram. If you're a little bit younger, 3 milligrams. Now, if you're in your 50s, I know 3 might not do a thing for you, so I'll say 5 milligrams. But I usually max out at 15, and if it's more than 15 milligrams, I send you to a sleep specialist. Or we try another agent if you're seen a sleep specialist already. Antihistamines, over the counter, people use a lot of Benadryl to help them sleep. Some sedating antidepressants. My favorite one is trazodone. Trazodone is my go-to. That's my favorite drug for sleep in Parkinson's patients. Number one, it does not interact with a lot of our Parkinson's medicine. Number two, it doesn't have a lot of side effects that are concerning, and then it works. It is an antidepressant, but in low doses, we use it for sleep. In higher doses, we use it as antidepressant. So if you go to pick it up at the pharmacy and the pharmacist tells you, here's your antidepressant, I warn all my patients, don't let that deter you from taking it. I'm not prescribing it for depression. That's what is FDA approved for, but we're prescribing it for sleep. It's a great sleep aid, except for one Parkinson's medication. It works with every other Parkinson's medicine, except for one. It's one of the newer ones. But other than that, trazodone is a great, great drug. Trazodone. Trazadone. I usually start very low, so 25, 50. I generally will max out at 200. Yes, generally. And, to be fair, majority of patients with some kind of depression, and it might not be clinically depressed, some kind of depression, sleep, it's always a problem. So a lot of these antidepressants do help with sleep. Trazadone. DON as in Nancy. Welcome. We have our non-sedating antidepressants, like our SSRIs. So you have your Zoloft, Celexa, escitalopram. And then we have our selegiline, which we use in managing Parkinson's disease by itself. It's also a monoamine oxidase inhibitor antidepressant, and that also helps with sleep. Then we have my least favorite of them all, the sedative type medications, Restoril. We use those, I personally use those as a last resort because by the name itself, they're sedative. They make you sleep, but then you wake up feeling groggy. And some patients, Ambien is one of them, that Ambien will cause you sleepwalk. It's known, that's a known side effect of Ambien. Doesn't happen to everybody, so we do have some few patients that do great on Ambien, and that's the only thing that has worked for them. You're not gonna deprive them of that. But however, it's just good to be aware that these things can happen. So if it happens to your loved one, you kind of know this is the medication that could be causing this. Any questions before we move to taking charge of your sleep? Perfect. The way to get started is to quit talking and begin doing. That's one of my favorite quotes from Walt Disney. Don't talk about it, just do it. With Parkinson's disease, number one, Parkinson's disease sleep issues, the favorite thing is to practice good sleep hygiene. Easier said than done, but that's the number one thing that you can do to help yourself take charge of your sleep. Good sleep hygiene. And what does that mean? Set bedtimes. You have a regular routine time for sleeping and a regular routine time for waking up. Keep your bedroom for sleep, not for work. Keep your bedroom for quiet time and cool down time. So know things that are activating your brain while you're in there, like watching TV, playing on your phone, playing on your iPad. Things like that should be living room things. And once you're stepping into your bedroom, you're changing your whole mindset, your whole aura about what you're about to do, which is sleep. Use your bed only for one or two things, sleep or sex. Avoid late daytime naps, because if you nap at 6 o'clock, you can expect yourself to go to sleep at 8. And avoid long naps. If you nap for 2 hours, you can't expect yourself to fall asleep when it's time to go to sleep. Avoid nighttime alcohol, nighttime stimulants, anything that stimulates your brain. Try to avoid that during the night. A lot of people say alcohol makes me have a good night's sleep. It helps me, keeps me rested. Then you take a glass of wine before you go to bed and you sleep for 2 hours and you're wide awake. So it really might help you go to sleep, but it doesn't keep you asleep. Try to sleep around 7 to 8 hours every night. Try some prudent exercising and eating healthy. And avoid stressful situations at night. Avoid horror movies. Avoid things that will just get you all riled up where when you go to sleep, you can't just calm down and rest. Because sleep is our rest time. That's our time to allow our brains to, our neurotransmitters to rejuvenate and regrow and wake up fresh and restored. In summary, sleep dysfunction is one of the major non-motor symptoms of Parkinson's disease that really does need to be addressed. Sleep disturbance negatively affects quality of life. In patients with neurodegenerative syndrome, the brain develops difficulty regulating the sleep-wake pattern. So it is important, very, very much so, to discuss this with your healthcare providers, get treatment, make some of those, take charge of your sleep, make some of those steps to get yourself a good night's sleep. 7 to 8 hours is optimal. If 6 works for you, that's fine as well. But the essence is quality. So if you're getting 6 hours of quality sleep time, that's very, very helpful to your Parkinson's disease. With that being said, I think my time is up. Thank you all for letting me come here and talk to you. If you have any questions, I can take them for you.
We have time for just 1 or 2 questions.
Yes.
If there's anyone that has a question.
You showed Benadryl as one of the aids. I remember years ago hearing that if you had Parkinson's, you were not to take Benadryl?
So it's not one of the ones that I recommend,
Oh,
but it's
okay.
one of the ones that are out there that a lot of people take over the counter is Benadryl. I don't recommend Benadryl because of its side effect profile and all of that.
Right.
Some Parkinson's patients do take it, but it's not our favorite thing. Yes.
Okay, thank you.
Do we have any other questions?
You suggested taking melatonin, and I was taking it for a while, but if you read the directions on the bottle, it says not to take it over an extended period of time, like over 2 weeks. And it's,
So that's like everything else. If you read the Tylenol bottle, it will tell you that someone could react to Tylenol. So those are some of the things that were mandated. So the drug companies are mandated to put on the drug bottles. Melatonin by itself is a natural substance that your body makes, right? And you can't control what your body makes. In patients with sleep disorders, sometimes they don't have enough of it, so that's why an additional melatonin helps. But it's something you can take melatonin for an extended period of time. Without it hurting you, yes, ma'am. You're welcome. If it works, then I'll prefer melatonin over trazodone. You could take both because melatonin will help with REM sleep behavior, trazodone will not. So you could have a provider have you on both of them because you're targeting different aspects of sleep. Yes, melatonin it does help with sleep, it does help with REM behavior, but trazodone does not help with REM. So if you have REM behavior sleep disorder, you could be on melatonin for REM, and you could be on trazodone for chronic insomnia. So it kind of depends on what's causing you not to have a good night's sleep. And you could be one of those that are experiencing multifactorial sleep disorders that we need more than one agent to handle.
We enjoyed having you here and tell us about all your good things under the sheets. But anyway, what I wanted to say is it's always funny to me when I look up one of these bottles and it says, don't take this because it may cause death.
I know. I think a lot of things that we give, some of them do say that. And we have to be mindful of that, right? If it says that, it means somewhere along the line it might have happened to somebody. So we have to mention it, yes. But thank you for having me. It's my pleasure being here.
Thank you very much for giving us a great presentation.
Thank you.
And we wish everyone a good night's sleep tonight. And in the interim, we have just the closing program for the next 45 minutes is back in the main room where we started. So thank you again very much for the presentation.
Thank you, Chuck.